Great. I think we'll make a start. I will open our webinar today with a whakatauki. Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kina kina ki uta, kia mā taratara ki tai, e hi ake ana te atakura, he tihau, he huka, he hauhu, tihei, Maori ora. Seize the winds from the west, seize the winds from the south. Let the breeze blow over the land, let the breeze blow over the ocean. Let the red-tipped dawn come with a sharpened air, a touch of frost, a promise of a glorious day. Kia ora, everyone. Welcome to our webinar today. My name is Andrea. Some of you might remember me from previous webinars that we did in 2020 about the future of public and community services. They are all on our website. If you're keen to check them out, please stop by and have a look and a listen. This time round, we are going to talk about the health reforms, and we are planning to do 3 webinars until Christmas to give you an opportunity to stay and be informed about the health reforms, about the progress that is being made and continues to develop, but also, of course, for you to ask a lot of questions and hopefully receive a lot of answers as well. So before I am going to start to introduce our guests today, I will just quickly go through how we are running the webinar. So I will introduce Martin, our guest today, and then Martin will do a presentation around about 15-20 minutes long. And then we'll enter into a conversation about the health reforms. Many of you have shared questions already in advance, so thank you so much for doing that. I will bring them into the conversation with Martin, and I would also like to encourage you all to use the question and answer function here in Zoom to post further questions, and I will be trying to bring them all into the conversation. As always in our webinars, if we don't get through all the questions that you're going to ask, we will be answering them afterwards. So please do ask your questions. You will get answers afterwards. One thing before we launch into the introductions, I would just like to make you aware of the new Future Health website that was just launched a few weeks ago. And you will find a lot of interesting and complementary information on that website. There's also a newsletter that you can subscribe to, and also the People Panui, which is particularly focused on the workforce. But also, of course, watch the PSA space. We will be recording this webinar and it will be available on the website, but also we are live streaming at the moment. So welcome to everyone who is joining us on Facebook. The video will be available there as well, of course, and much more information as always. So, Martin, a very warm welcome to you. Great to have you here. Thank you so much for making time to be with us. You have more than 20 years experience in the health sector, and you're currently the Deputy Director of the Health and Disability Review Transition Unit, which is located with the Department of the Prime Minister and Cabinet. So a very warm welcome. I would like to ask you to tell us a little bit more about yourself. I mean, why have you had such an interest and commitment to the health sector as such? But also now, why are you interested in changing the health system and take on an important role in supporting that reform? Tell us a little bit about yourself.
Sure. Thanks, Andrea, for the opportunity to be here today. And kia ora to everybody out across New Zealand. Hope you're enjoying your sandwiches and having a bit of a break. A little bit about me. I'm a Ngaki boy, North Taranaki, Aho. I'm from the metropolis of Opunaki, where my dad was the local GP. He was the country GP, and he was the only GP. He looked after the local town, and he was, it was kind of the heroic age of general practice, where he was on call every day and every night for days and weeks and months at a time. And the only time he had a break really was when he had a locum in to cover things. And it was a rural town, so it wasn't that attractive for locums, but I remember one time he and my mum went away on a long holiday, and they actually went overseas, and he arranged for a young doctor to come and his wife to come to locum for the practice. And the deal was that they looked after the practice, they lived in the family home, and they had to look after us 4 kids as well. So can you imagine nowadays trying to find a locum who would come and not just look after your patients, but also your children for a couple of months. So yeah, it was a great place to grow up. But I got interested in health myself more living in Palmerston North when I had a flatmate who had bipolar disorder, and he unfortunately killed himself, as so many people, young people do with serious mental illness. And that got me interested in mental health. And sometime later, I ended up working in an NGO, working with people with serious mental illness and their families, and became pretty unhappy with the system pretty quickly, as I think anybody who worked in the 80s in mental health would have done. We used to spend most of our money in mental health on institutions and on places like Pororo Hospital and Lake Alice and Ngāwhatu and so on. And I ended up moving from the NGO into the Regional Health Authority when it was established, and had an opportunity which not many people get to try and change things from a commissioning point of view. And we did close down some of those institutions and moved that resource into community mental health. And I think that improved the life of a lot of people, but I reflect that there's another revolution needed to kind of actually integrate mental health and personal care, and to integrate primary care and secondary care in mental health services. So we've only done part of the job, I think. So yeah, I mean, like most people, a mixture of personal stuff and professional experience got me interested in health. Now I live in Wellington. I've got 3 grown-up boys and 2 dogs who keep us very busy.
That's awesome. Thank you so much for sharing that with us. I think you have a presentation now, Martin. Maybe we'll go into that in order to get a little bit of an overview, what the health reforms are about, why we need them now, and what some of the pillars of the health reforms are as well. You want to share your screen? Does it?
I definitely do. Here we go. We'll try this.
Fantastic. So the floor is yours for about 15-20 minutes, and then we'll launch into some of the many questions that I have here on my sheet of paper. Thank you so much. You go.
Okay, good. And if I start dragging on, then just hurry me up, Andrea.
Absolutely.
I really want to get to the questions and keep it lively. So just really good to give the opportunity to give an update where I've been working with the transition unit since December last year, and we put cabinet papers up, and cabinet agreed to some major changes back in March, and Minister Little announced them in April. So since then, we've been busy working on implementation of those policy changes, and I'll give you a quick run through of some of the key features. The vision the ministers announced is Pai Ora, Healthy Futures, and that's the name given to the bill, to the legislation that has been introduced into the House to bring about these changes. Not a new vision, I don't think. Paiore, Healthy Futures. We've been after that, all of us, I think, in health for a long time. But there are some nice features associated with the model that I'll go through, which I think will help us to achieve it in future. Part of the, kind of some of the why change, and I guess I would say I don't think our health system is broken. I think that it's not as good as it could be, and for some people it works better than other people. And we know that in terms of health outcomes, Māori, the life expectancy is something like 7 years less than non-Māori. We know that they're twice as likely to die from an avoidable condition, 60% more likely to be admitted to hospital for an avoidable reason. So Pacific, similar statistics, and for Pacific people and Māori people, you can see with other statistics that part of it is about, they're not engaging with the health system. And, people talk about hard to reach populations. I think another way of looking at it is that some services are hard to access if you're working in a job that is not easy to get leave from. It's not that easy to get to for instance, a general practice appointment that's only during the day, or that you have to pay more than you can afford for. And then, we know that people with disabilities don't fare particularly well in the system. We don't know what the life expectancy gap is because we don't record disability properly in any of our national information systems. We do know that people with serious mental illness tend to die 25 years younger than people who don't have a serious mental illness, and most of that gap is avoidable, is things that are related to us having a system where we might provide really good care for your schizophrenia, but we're not looking after your diabetes or your heart disease or those things. We split off mental health in our health system. And some of the system changes we've been working through that we think are needed. One of them is around a health system that reinforces treaty obligations and that complies with them. And there's a recent ruling by the Waitangi Tribunal, the Y2575 case, in which they said that health policy, and particularly the primary healthcare policy over the last 20 years, has not complied with treaty, has not looked after the interests of Māori, and has not recognised the higher needs of Māori in things like capitation formulas. And you can see that if you look at a medical centre in a really high need area in say, far north, they're getting the same rate per person for core capitation as a medical clinic in Remuera or Kelburn or somewhere. So, that's clearly not fair. And they've also, the Y2575 also pointed out that, that funding in primary care has only been based around GP and practice nurse resources, not the wider team that you need to deal with, to help people who've got more complex social needs or clinical needs. So, yeah, I mean, the whole, we'll come to it in a bit, but we need specific changes to meet our treaty obligations. And then the whole comprehensive range of support in local communities. We still have mostly GP and nurse services. We don't have comprehensive primary care teams. We don't have common access across services in New Zealand, and we are starting to lag behind there. We can do so much better than we do now. The next one there about equal access to high quality emergency and specialist care. Of course, we live in a long, skinny island, and geography is an issue for us, and we have a spread out set of populations. But even within that, there are very strange metrics and stats that come out when you look closely. You can see that things like knee replacements differ by about 300% in terms of access rates between DHBs, and the specialty services, it's much easier to access them if you live in a big city with a tertiary hospital than if you live in a provincial or rural area. And that's not just about distance, but about our divided up system, 20 district health boards, each with autonomy and budgets and making its own rules, creating its own health system. It's created a bit of a postcode lottery that we need to reverse so that we get fair access to services across New Zealand. The fourth one there is about digital services and recognising we used to be world leaders. We were one of the first countries to really adopt electronic health records in primary care, and we're early movers in digital services. But our investments have been fragmented, and each DHB has made their own choices in digital services, and we have really lagged behind. We're not providing the kind of care options for virtual specialist visits and virtual GP visits and booking online and changing services online and helping people to manage their own health in their own home and community in a way that we should. And then the fifth one is really about valuing and really training our healthcare workforce. And some DHBs have done this well and some have not done it well, but it's too important to be left up to the vagaries of whether an individual DHB considers it important or not. We need to work on it consistently. You can see, Andrea, why I said you'll need to watch the time for me. I can talk to this stuff for a long time. Anyway, the big structural changes I think people know about now. They know that we're intending to merge 20 DHBs and their 7 shared service agencies into one Health New Zealand. Health New Zealand will be the employer for all of those staff, and would be organised in regional and sort of sub-regional local arrangements. Health New Zealand will also run kind of key divisions, one of them being hospital and specialist services and focusing on getting that equity of access and efficient delivery across New Zealand. Another being the primary and community and the National Public Health Service, and having a balanced view, like not letting hospital and specialist services kind of eat into the time and resources we should be devoting to prevention and promotion and early intervention and screening and so on, and really not separating them, but keeping a separate focus on them. They're all in one organisation, but we've got to not let important hospital services kind of override the equally important primary and community and public health stuff. And it's so easy for that to happen. The other new entity is the Māori Health Authority, and this is one of the recommendations from the Waitangi Tribunal. It's now been set up as an interim health authority, and it will have a number of functions. One is it's an alternative policy advisor for the government on Māori health policy, and will give independent advice to government. Secondly, it will commission and have its own budget to commission services from particularly kaupapa Māori providers, and be able to recognise the Māori worldview, Te Ao Māori, and support that view through Māori providers. And that'll be important, and nurture them. Then the third bit is around co-commissioning with Health New Zealand. So the Māori Health Authority and Health NZ are going to be joined at the hip, and will need to jointly sign off on any major service strategies, service plans, the New Zealand Health Plan, which we'll talk to in a minute, Health Charter, etc. All of these things will be jointly commissioned by Health NZ and the Māori Health Authority. And the fourth role is as an overall system monitor, to transparently report how we're going on Māori health. The localities bit is this slide is starting to talk about a focus on population health, and starting with obviously our whānau and iwi and communities, and recognising rangatiratanga and giving people to have the opportunity to have as much control and power over their own lives and health as possible. And as part of that, first of all, getting our own act together and joining up primary and community care and integrating it with hospital and specialist services. And I give an example of where I see disintegration now. Currently, if you're a woman, a pregnant woman, you'll find yourself, hopefully, a midwife, a community midwife, and that person will take you through labour and birth and help you deliver your baby. But they don't have any connection and usually won't talk to your GP or practice nurse or primary care team who are providing the other bits of your care over that period. And then they'll hand over to a well-child tamariki ora nurse who will help you look after your baby and make sure they grow well. But they don't normally see each other or talk to each other. So the well-child nurse and the midwife don't connect up as a team. And then the well-child tamariki ora nurse also generally doesn't have any contact with GP or practice nurse that you're taking your baby in to get immunisations or looked after when they're sick. And I think we couldn't have created a more fragmented system if we tried. And if you're really well and your things are all tickety-boo, it probably doesn't matter. You can get yourself to the GP and you can organise a well-child nurse and all that. But if you have complex needs and we need a more connected response, it's very hard to do the way we've organised things. Then just calling out and recognising that health services probably only account for about 20 to 30% of health outcomes. And so we need to get our head above the health kind of parapet and look at some of the other big influences on health, which our public health services have known about for a long time, things like access to clean water and good air, which in New Zealand usually is not a problem, but every now and then, I think about Havelock North, we had the example there of water that was bad. And we know that in some of our cities, the air quality is not always what it should be and drives up rates of respiratory illness. So, those are key things. Access to green space. We know if you don't have that, your mental health is likely to suffer, and we are working to increase density of housing in our cities. So the strategies around the built environment and the natural environment and transport, we've got to work more closely with local authorities to influence and be part of those decisions, because they affect health. Then on the right-hand side, the Māori ora health-related behaviours and lifestyle factors probably have a bigger determinant on health outcomes than actual health services. And that includes things like, whether we drink and how much we drink, and drug use and physical activity and how much we eat and what we eat, and the smoking, whether we smoke or not, and sexual behaviours and gambling. Also the kind of the resilience we have, whether we have learned to manage anxieties and day-to-day stresses of life in a way that's productive. So affecting health-related behaviours has got to be a goal. And that's where organisations like the Health Promotion Agency have been strategising for some time now. The other part of that is the socioeconomic determinants. And we know that, if you live in a deprived area, then there are more likely to be liquor outlets and more likely to be gambling machines, and more of them in that area. And you're likely to have less, the public transport is not as good and some of the amenities are not as good. And so, housing, education, income, sense of belonging, and whether your culture is valued or whether you face racism daily, these are all the things that make a huge difference to health that we need to start to engage with in a local way and in a way that isn't about coming in and saying we know best, we are health. We need to work with the other agencies and institutions and communities and local iwi. So the intention is that we kind of identify communities of interest and localities and develop place-based, longer-term plans for services and for integration in each of those areas in New Zealand over a period of about 3 years. And we do that hand in hand with local iwi. We recognise in getting rid of DHBs, we are getting rid of the people who are elected from local communities. We do believe there are better ways of getting a consumer voice than the vagaries of elections, and that if we're developing a purposeful framework supported by the Health Quality Safety Commission that will work to make sure we have engagement from consumers at a local level and also at a national level. The Health Quality Safety Commission will put together a national forum for consumer voices, and the intention of that is to make sure that we don't lose the diversity of particular groups within the mainstream voice that can sometimes overshadow individual voices. Another part of this, and this is moving from structures to now kind of hearts and minds. Ideally, whether you work as a practice nurse in a GP clinic or a paramedic in the ambulance or an ED administrator or a ward nurse or a specialist, currently you think, oh, I work for a DHB, I work for the ambulance, I work for my GP employer, whoever it is. That's fine, you're employed by those people, but actually we all work for the health of our New Zealand population. And so the Health Charter is intended to be a bit of a bridge across all of the different parts of the health system to draw out some common values, expectations, behaviours, the things that join us up and that are shared as part of working in health and wellbeing. We don't know exactly what form it'll take, but the intention is to develop it over the next 6-8 months for next year, and we want a lot of engagement and involvement in that process. Another thing over the next 6 to 8 months is developing the New Zealand Health Plan, and this is a new feature. We haven't really had clinical services plan for New Zealand covering all of our services over an extended period. So this, the New Zealand Health Plan will start to say, well, okay, this is where we'll provide tertiary services and how we'll organise tertiary services so that while we might have to get people to travel for surgery or for radiation therapy or something like that, how do we make sure they can get as much as possible locally and have it integrated with their local hospital and services? And so this will also set the scene in terms of changes in the way we want services to work over the next few years. And we will be Health New Zealand and the Māori Health Authority will be required to develop this New Zealand Health Plan, and it'll then be approved by the Minister. And it will go down to quite a lot of detail. We'll be able to say, well, look, we know how many babies are likely to be born across New Zealand and in each area over the next 5, 10, 20 years. We know how many midwives we have now, how many we need based on this births, and we can start to do proper workforce planning and say, well, okay, given what we know, we're going to be short or maybe we'll have a surplus of a certain health profession. It's never happened before, but you never know. So we'll be able to do long-term planning around, what is the workforce we need and what are the models of care we need to change, either because we don't have the workforce to do it in a certain way or because it's going to be better for people. And in some areas you say, well, okay, we're not going to have enough GPs, for instance, into the future. So can we develop more nurse practitioners and pharmacists, clinical pharmacist practitioners, prescribers, and other professional allied health roles that can take on some of what GPs do now and probably do it better. So the New Zealand Health Plan is a really important thing, and that will come out in draft for everybody to have a say on, probably around March next year. Data and digital, I've talked a little bit about the opportunities are huge in data and digital, and you may want a further webinar one day with our the people who are driving some of the agenda around data and digital. I think might be a good idea. And then what does this all mean for the workforce? Planning I've already mentioned. We can plan our workforce in a way that doesn't happen at the moment. And we can liaise with our tertiary institutions to say, well, actually, we need you to train more clinical psychologists. The number of places at the moment is woefully inadequate currently. And maybe we also need some more courses that might be about CBT practice, not being full clinical psychologist, but being able to provide therapy, evidence-based therapies for people. And maybe we want to change some of our things like our training, some of our training programs to be more apprenticeship and micro skills based. And things like leadership as well, leadership and management. We've all had, well, maybe most people I know have had a terrible boss, a terrible manager, and someone that they found it really hard to work for. And if you talk to people, it's one of the things that makes life miserable is if you have a manager that you don't feel does a good job or doesn't respect you or look after the team. And I think about that, and I think about how well we prepare people to be team leaders or managers, and what we could do to make sure we've got really good training for these people, and then what we could do to make sure that across New Zealand we know whether teams are feeling like they're not supported by their manager, and have a way of recognising that and doing something about it consistently. And then Māori and Pacific people tend not to be in the regulated workforce as much. So there's work to do to encourage them to get into nursing and medical and physio and allied health schools and so on. But many also are not necessarily in the position to take up tertiary study in the same way. And so what can we do by way of getting some of these people come in as kaiawhina or unregulated roles, and can we staircase them into regulated roles over time with micro-credentialing rather than having to take 3 years out to do a degree. So opportunities to rethink some of the health workforce and to modernise the way we work. We will be, the 80,000 odd people that currently working in DHBs will be employed all through Health New Zealand and a small number through the Māori Health Authority. Also, in terms of workforce, to recognise if we want to have a common charter and a common set of goals across DHB employed and privately or third sector employed people, then we're going to need to have common kind of remuneration and pay and conditions over time as well. So pay parity becomes a question. And I think that's probably enough of an introduction, Andrea. I'll quickly note that we are on track. This is a timeframe that was developed back in February, and we're on track. The interim Health NZ and the interim Māori Health Authority boards have been appointed. The legislation's been introduced to the House, and we expect the legislation to come out around about May next year, and it come into force 1 July next year. So we're on target at the moment, which is not bad for a major and ambitious reform. See if we can keep it up. Yeah, thank you. I'll stop sharing.
Kia ora, Martin. Thank you so much. Lots of information there to digest and to reflect upon. And as I said, we have so many questions, so we might as well get straight into that. First up, though, before I get into the questions, I would like to highlight the key system changes that you mentioned in your presentation at the beginning. And I'm sure all of our members are very pleased to see a strong focus on valuing and training the workforce for the future health system, and also that the health system can and should really reinforce Te Tiriti principles. The big question, I guess, is why. It's not why, how, of course, not why. How we do that. And I'm sure we'll get to that when we touch on some of the questions that people have posted in advance and now are posting in the chat. So maybe a first question about the leadership and culture that we see in the current health system. I think there are a number of questions that touch on that, and you briefly touched on it in your presentation, but I was wondering if you could elaborate how we actually shift to a more people and worker-centered leadership approach, but also culture within the health system. How are we going to do that?
And I'll be interested in you know, the people out there's thoughts as well in the chat. My go around talking to people, and I was in, I think it was South Canterbury, Timaru, and so someone in the audience said, look, we used to have not a very good culture, and you know, we didn't feel valued and things weren't great, and now we feel like, you know, we're listened to, and you know, there's still only the same amount of money, but there's a culture of respect, and ideas are taken and implemented when they can be, and you know, it's quite a different feeling. And that came down to leadership. When I asked them about what was the change, it was a change in leadership and the kind of values and ethos of the people in leadership roles makes a huge difference to what people experience and how they experience their work. And that's got to be where it starts, is making sure we have leaders who do live the values that we end up putting into the health charter, whatever they are, and can be held to account for that. And I think I mentioned, I almost imagine us having a heat map across New Zealand in terms of, you know, understanding every team and how they're going in terms of the team climate, and knowing where there are problems and being able to do something about it, either by providing further training for leaders, or you know, if people are not able to lead in the way that we want in future, then thinking about other options.
Yeah, I think that's a really important point. A leader that believes in learning rather than controlling, if you like, or directing, makes a huge difference. But I guess it is also important to recognize workers as leaders in the positions that they are in, and the knowledge and experience that they bring to the role. And I imagine that a lot of our members would suggest that participation of those workers and frontline workers would help to improve the culture, but also, and more importantly, maybe even help to deliver those high quality services that the public needs and deserves. So I wonder how that participation is or could be built into the future health system. You already touched upon the charter, I guess, as one mechanism. Would that be something that could enshrine that?
Yeah, the charter, I think, the health plan and the way those documents get created is important. Your point about participation, I think, is a good one. And it's got to be kind of day to day, doesn't it? It's like, everyone has two jobs. One is to do whatever their job is, the other is to keep making it better. Like we've got to keep thinking about how can we do all this better? How can we do it better next time? And the kind of the ethos you want, I think, in this big system like this is the idea of servant leadership, that the point of management and leadership is to support the teams that do the work and not the other way around. So I think the charter could be a good way of anchoring that into what our expectations are of each other.
Yeah, thank you so much. We also had a number of questions that related to prevention and promotion of health rather than intervention. So I think the intention of the new health system is to focus more on prevention and promotion. How are we going to achieve that? I think particularly when thinking about primary care, you elaborated on that and how it might not yet be fit for the future, also in terms of free access. So how are we actually ensuring that prevention and promotion becomes a reality for everyone?
So one of the things that's happened over the past 20 years is that the proportion of the health resource that we spend on hospital and specialist services has increased relative to what we spend on promotion and prevention and primary care and public health. And public health services in particular have not really had an increase to keep up with inflation over the past decade or so. So one of the proposals is that we differentiate the budgets for these two sets of services so that we have a kind of an appropriation for public health, primary care and community care, and a separate appropriation for hospital services. And that means that we can kind of estimate both, but it protects the promotion and prevention side of it. And it means that when governments want to, as they often do actually, want to emphasise prevention and promotion, they can increase that appropriation and not worry about it being sidetracked into hospital specialists. Not that there's anything wrong with hospital specialists. I don't want to get the idea that I'm anti-hospital, but we need to make sure we keep the balance. The point about free access it's kind of a budget question that governments decide from time to time what they want to make free or not.
Yeah, thank you. We also got a number of questions around the NGO sector, including NGO services or community services and respite services. How will they be affected to start with by the health reforms? Are the health reforms relevant to the community sector? And what will it mean for providers in the community sectors and the contracts that they are holding at the moment? Will they operate or will they have to operate differently?
So in the very short term, the aim is to avoid disrupting frontline services and frontline teams. And frontline really includes not just people laying hands on patients, but also the people who support those teams, administrators and corporate services. So what we're going to do is everybody's employment who works in a DHB or a shared service agency will automatically transfer into Health New Zealand with the same terms, conditions, leave balances, all that sort of thing. And that'll happen automatically without any disruption. We aim to do the same in most of the community and NGO and primary care and kaupapa Māori contracts, where we'll automatically continue those service contracts and use legislation to wrap them into Health New Zealand, without anybody having to re-sign anything or renegotiate anything or losing money, etc. And we are trying to make sure we do that as seamlessly as possible. We've got people who are trying to keep a track of, it's about 16,000 individual contracts with community providers to make sure we don't lose any in the way over. And they'll also be trying to work through, well, what goes to Health New Zealand and what is going to come through into the Māori Health Authority. So we'll really want to avoid any disruption in the short term, but part of that, I mean, we do want to have changes. We want to improve things, and the big shifts that we're expecting in terms of the way things work and models of care will be flagged in that New Zealand Health Plan, and people will all have an opportunity to look at that in draft and say, well, look, that makes sense or that doesn't make sense, etc.
Thank you. Linked to the provider and NGO sector, providers and NGO sector, but also DHBs, we had a number of questions about services that fail Māori and Pacifica, but also disabled people's needs. So how do we make sure that that doesn't happen in the future system? Is there a way, or will there be a way to hold the respective organizations more accountable to what they are actually providing, and if they are meeting the needs of the population?
Yeah, it's a really good question. I mean, the point, and I saw a couple of comments online as well, you know, where the aim is to improve equity, improve health outcomes for everybody, but also for particular groups that are not doing well as well at the moment. And we're putting in place some structures and processes like the Māori Health Authority, like locality plans, that should make a difference. And we will be putting out quite clear information available to people to see whether that's working or not. I guess if it isn't working, it can be quite hard to hold any one provider to an account. You know, like, is it the is it the fault of an individual provider, or is it because of the deprivation and the issues in a particular area that are making the difference? And we're seeing that playing out now in COVID, aren't we? We're seeing COVID vaccination rates differing by community, and we understand that, you know, for some individuals, there's a lot going on in their life. Things are in a difficult state, and actually getting a COVID vaccination is not the most important thing in their life right now. And that's understandable if you understand what's going on in their life. And so we have to make it as easy as possible for people to do it, and as attractive as possible. And that applies to so many other services as well, doesn't it? So, and it's perhaps not individual providers being held to account, but the way we're delivering services overall. There's a question here, Andrea, I saw from someone called Alistair, about how will the problems of centralised control and management be mitigated? And I thought that was a really good question. And it is a risk, isn't it, when you create a really big organisation? Might we end up with a bloated kind of bureaucracy in Wellington, which holds the control and manages everything, and, you know, nobody can get anything done out in the real world? That's the last thing, obviously, we want. What we want is not a centralised system, but much more of a distributed system. There's no reason why someone couldn't be in the national team for whatever it is, but be working in Nelson or in, you know, in Whangarei or wherever. And the design has got to be about local decision making.
This is again about the system being people-centered, isn't it? And how we make sure that the centralization of services doesn't move us more away from people than we are right now. So how do we connect the central system to the communities? And that, I think, is one of the main questions. And how do we ensure that the voices of those in those different places, regions, towns are actually heard?
That's part of that locality, really, because you want, the people of Wairoa will know the best way to organise things in Wairoa, and the national arrangements we have for things like funding maternity services probably don't work well in Wairoa, but if we make the resources available, they can figure out different ways to do it, and maybe that would involve training, maternity assistants locally who can understand local culture and have good connection, and we can use some of the money because you're not going to get enough midwives working there probably. So can we do it alternate ways that achieve the same outcome?
Yeah, thank you. I would. There was one question about the number of health reforms that happened in the past. Obviously, this is not number one. We had several of those in the past, and if a person comes to you and says, look, I've been through so many of these, and unfortunately, they never really achieved what they were set out to achieve, what would you tell this person? Why is it different this time? And how do we get there? How do we really make sure it's happening this time? How would you give people the confidence that this change will be substantial and sustainable?
That's such a good question. And I've been involved in health reforms as well. Like I was in the Central Regional Health Authority and Health Funding Authority and worked in DHBs and so on. And I think you recognise that every structure has pros and cons. Like DHBs have been able to do some wonderful things in very small areas, but we've been really bad at scaling those initiatives up across New Zealand. We've been really bad at saying, well, okay, this great thing happened in Tairāwhiti or somewhere. Why don't we make it available elsewhere? And implementation and reforms is everything. Policy is really important, but it's the implementation that really, really matters. And so I think we need you all to hold us to account through this implementation and hold government to account that the actual kind of resource allocation and structures that get developed do respect the kind of the aspirations that have been articulated by people. And so, I and the team here will do our best to make sure this happens in the way that's intended, but keep holding us to account. These sorts of conversations are really good for that, because it just reminds, it kind of reminds us all what's working, what's not, keeps it real.
Thank you. No, we will certainly continue to hold you to account. So no doubts about that. And I would suggest that, making worker participation an integral part of the health reforms will bring us closer to achieving the goals that we are set out to achieve. I know you are planning to do that. You are already engaging a lot in terms of the structure, in terms of the different plans that are underway, of course, the charter. So it's a very exciting time for us to be involved in this. So thank you so much for making the time. I know that we have so many more questions. So thank you to everyone who posted their questions. We will absolutely get to them, and not obviously in this webinar, but we will get them to Martin, and you will receive answers to those questions. Thank you so much. As I mentioned, if you enjoyed the conversation, please share it with your family and whānau, with friends, and of course also with your colleagues. The recording will be available. But before I close today, we have a new feature for our webinar. We will have a little mini poll that you will see now on screen. And we thought we'll give you the opportunity to actually vote for the next topic. I indicated that we'll have a webinar in November and one in December. So you can actually choose the topic by just clicking on your choice. So you have the option of using localities to tailor care. So this is about bringing the health reforms to the people, to the regions, to the towns, to the places that Martin talked about, and how we bring those voices in. The second option is about the health charter for the workforce and the health plan, which is about the delivery and design of services that Martin touched briefly about in his presentation as well. So please vote now, and we will see what the next topic will be. Unfortunately, I'm unable to vote, so I can't see the poll as such. But do we have the results somewhere, please? Ah, wonderful. So that was actually quite close. So we have 45% of our participants have chosen localities and 55 the health charter and the health plan. So the health charter and the health plan will be our next topic, and localities will be our topic for December. So thank you so much, everyone. It was a pleasure to talk with you, Martin, but also thank you to everyone that came along for all your questions and your interests. I hope you enjoyed it. I will close with a whakatauki, and then I hope to see you all next time. Nau te roro, naku te roro, ka ora ai te iwi. With your basket and my basket, the people will live. Thank you all, and stay well.
Kia ora, thank you.